I will go on to my topic now. Thanks, Dr. Anand. Can I have my slides, please? Yeah, from my laptop. So I'll be talking about retinal pigmentation. Could it be life-threatening? So sometimes we take retinal pigmentation to be just innocuous, benign stuff, but it can be sometimes major. It's a major problem which we can face. So these are the various causes of giraffe or leopard spot chorioretinopathy, and I'll be showing you some cases which were actually life-threatening, like with primary intraocular lymphoma, B dump, and choroidal mets. So this is my first case. I call it a leopard can't change its spots. A 57-year-old female, 11 years ago, presented with low-grade vitritis. Systemic investigations were largely non-contributory. The saga continues. 2 more episodes of bilateral low-grade vitritis, uveitis panel non-contributory. Lost to follow-up for 7 years, returned in 2021 with floaters OU, with right eye counting finger close to face, vitreous cells 2+, glaucomatous cupping, and multiple pigmentary changes and intraretinal hemorrhages. This is what the pre-treatment ultra-wide field color fundus photo looks. Not much to see here, but the SSOCT we got done, and it had sub-RP hyperreflective deposits with a neurosensory detachment in the right eye and a band-shaped infiltrate at the choroidal level, which you can see here in the left eye. And the media was hazy, and when we did the FAF, it had a remarkable, starry sky appearance or a leopard spot pigmentation, which you can see more clearly in the left eye. This is, on the ultra wide field FAF. And pre-treatment FFA also showed this remarkable appearance of a starry sky or a leopard spot pigmentation, more marked in the left eye. So normal peripheral blood smear was there. Ultrasound abdomen was unremarkable. Chest X-ray did not lead us anywhere. CSF analysis did not show any atypical cells. The cellular bone marrow preparation showed no morphological evidence of lymphoma. A PET scan showed no abnormal hypermetabolic focus or mass lesions. The patient underwent a EBUS TBNA from the mediastinal lymph nodes, showed just reactive lymphadenitis. ZN stain was negative. No evidence of metastatic carcinoma seen. And on immunohistochemistry, no definite evidence of lymphoproliferative disease. Finally, the patient underwent a diagnostic vitrectomy at RP center, and what came out was a T cell positive CD4 lymphoma. And these are the slides courtesy RP center from Dr. Seema Kashyap and Dr. Nawazish, and which were confirmatory of CD3 positive T cell lymphoma. So the diagnosis was a bilateral primary vitreoretinal lymphoma of T cell origin, and she was administered over the next 1 year 25 intravitreal methotrexate injections as per the protocol. And these are the, how it resolved. And you can see that all the changes of the choroidal infiltration and the subretinal fluid have resolved. And so has the leopard spot, pigmentation on FFA and ultra wide field imaging. So it's important to remember leopard spot pigmentation in an age group which is more. And uveitis is, you always have to have the high index of suspicion, in these cases of extremes of age. So the second case, lumpy bumpy choroidal conundrum. Presenting complaints, 82-year-old female, left eye diminution of vision since 20 days, vision of 624 parts in the left eye. This is what the fundus looks like, nothing much here. But on FAF, you can see this lesion along the supratemporal arcade. And on the angiogram, you can see that, again, a leopard spot kind of pigmentation. On ICGA, there's a hypocynescence. And this is what is the giveaway. And on OCT, you can see that, marked neurosensory detachment with a lumpy, bumpy choroid. And in the choroid, you can see that the stroma is actually pushing the choriocapillaries, and the choriocapillaries are compressed. Hardly any choriocapillaries layer there. The other investigations were within normal limits. Patient was initially, put on steroids. The SRF regressed, but then she came back and she gave a history of infiltrating ductal cell carcinoma of the breast, ERPR positive, which was treated with MRM a few years back. And she was already on Memofen for the last 3 years. And detailed systemic examination showed, systemic metastasis. And so she was diagnosed as a case of choroidal mets. And after systemic chemotherapy with palbociclib, you can see on the left what the patient had initially, and after systemic chemotherapy on the right side, right bottom, you can see how it flattened out. And this is the change analysis. You can see the choroidal mets just dissolving with systemic chemotherapy. This was published in recently. And so the symptoms and signs can be varied, and there can be different colors of these choroidal mets, where in the lung you can have a pale yellow color, in the breast a lobular creamy white color, prostate can have an amelanotic mass, renal carcinoma is typically a temporal orange color and pale yellow juxtapapillary mass, and a lung carcinoid is orange. Thyroid tumor is likely to be a subfoveal orange color mass. So conclusion, history taking should not be neglected because she did not give this history initially. Any patient with a history of carcinoma should be screened with a high index of suspicion for metastasis. I call my case 3 great gig in the sky or dark side of the moon. You'll see why. 58-year-old male presented to us with decreased vision in the right eye past 2 weeks, in the left eye for the past 3 months. Seen elsewhere, diagnosed as CSR, innocuous looking CSR. You can see here on the OCT that there's a neurosensory detachment and a PED. Anybody would just diagnose this at CSR and just call the patient after 6 months. But 6 months is too long for this patient, as you shall see. 3 days prior, this was the OCT. And when he presented to us, we did an angiogram which showed this starry sky appearance. And you can see some hyperfluorescent areas there. And this is what was the giveaway again. You can see some choroidal infiltration on the swept source OCT with alternating RP thickening and RP loss. And there was, of course, subretinal fluid. And leopard spot pigmentation with a characteristic giraffe pattern seen on fundus autofluorescence. Past medical history was again elicited, and the patient gave a history of nephrectomy, and for which she was investigated further and diagnosed as renal cell carcinoma. He did not give this history to the other ophthalmologists. We did an ultrasound abdomen which just showed widespread metastasis all over, and a PET CT confirmed the same. And then he was diagnosed to have a paraneoplastic condition called B-dump, which is bilateral diffuse uveal melanocytic proliferation secondary to metastatic renal cell carcinoma. Patient refused plasmapheresis, was advised sunitinib treatment by the urosurgeon, which is primary chemotherapy. Did not do well after that, as you shall see, that the SRF kept increasing, and finally patient landed up with an exudative RD and went on to have a closed funnel RD in 7 weeks. 3 months post-initiation, patient had NVI with NVG with a lost eye, and the PET CT just confirmed widespread metastasis. Patient refused external beam radiation therapy, was put on second-line chemotherapy with everolimus, but finally was lost to follow-up. This was recently published as well. So B-dump is a rare entity. It's a paraneoplastic syndrome. Ocular signs precede systemic manifestations by 3 to 12 months. These are the 5 cardinal signs which were described by Gass, which are multifocal, faint, round or oval red, subretinal patches, leopard spot pigmentation, multiple slightly elevated pigmented or non-pigmented uveal melanocytic tumors, exudative retinal detachment, and rapid progression of cataract. It's a hallmark of a grave systemic condition. We need a high index of suspicion. Important to look into systemic details, especially with patients presenting with apparently innocuous findings such as CSR, and diagnosis of occult primary malignancy can be challenging. My last case, a double trouble. So yet another lumpy bumpy choroidal conundrum. Patient with 618 in the right eye, 66 in the left. It's a 58-year-old male. On the fundus picture, you can see some changes in the right eye, just above the disc, and in the left eye in the inferior fundus. Thanks to Optos, we could pick these up. And this is what is more remarkable, is the Optos fundus autofluorescence. And on OCT macula, we again have, the obscured choriocapillaries layer with a lumpy bumpy configuration, and SRF with shaggy photoreceptors and speckles, which are very characteristic of metastasis. This is what the FFA and ICG look like. I showed you this in the first case. And this is what the ultrasound B-scan looked like with a huge mass lesion with choroidal excavation. So with the provisional diagnosis of choroidal metastasis, the systemic workup was done. The CCT chest showed some lung apical segment mass lesion, and ultrasound abdomen, MRI brain, and MRI orbits were non-contributory. Patient was referred to higher center, managed at PGI Chandigarh, where a PET CT revealed widespread metastasis, with the primary being most likely a non-small cell lung cancer. And patient was started on chemotherapy with paclitaxel, carboplatin, and bevacizumab. And this is a follow-up in March. So by this time, patient had received only the first chemotherapy, and you can see there's not much regression. And this is the recent follow-up, which is just a couple of days back. And you can see that the choroidal mets have just melted and just flattened out with a lot of pigmentation. and you can see these changes on the fundus autofluorescence. And the above OCT was at the first visit, and the bottom one just 2 days back. So with the systemic chemotherapy, the lesions have just flattened and they have regressed. So this is the serial change analysis. So just to conclude that with the high index of suspicion, all these cases of pigmentation apparently which is innocuous retinal pigmentation can have a grave systemic underlying disorder which needs to be managed. Thank you.